I'm Mike Lubin. I am the head of growth for Hint. You guys have seen me over the last day and a half. I'd like to introduce Jen Rabiner. Jen is our product CEO. For all intents and purposes, she runs product and everything that we build and develop at Hint. And we want to spend a few minutes and tell you about, kind of building on Sean's discussion, tell you about the work that we're doing in partnership with the Health Rosetta to help to solve some of the challenges that were brought up in the last discussion. And some of the work that we're doing to help solve challenges that Health Rosetta benefit advisors are having in the marketplace who are interested in learning about and or want to start to work with DPC doctors. It's interesting, I mean, Jen and I were talking in the last discussion. A lot of that, by the way, is just education about DPC, which I'll be touching on. But in Sean's discussion, we were like, I think there's an equal opportunity to provide more ongoing and structured education to the direct primary care organizations that want to move in this direction or need more sophistication on this stuff versus an excellent slide deck from Jeremy Smith last year or from Sean from this presentation. So I think we've taken note of that. I think I need a clicker maybe.
Sean stole our
Oh, I have a clicker. Okay. Cool. So I'm going to take 1 second, just give you a little background on Hint. I'm going to do so because I remember after last year's Hint Summit, there was, I don't know, maybe a good 6 or a dozen people that reached out to us afterwards. They said, that was the most amazing conference. You know, it was incredibly informative. You know, thanks so much for putting it on. And they said, what do you guys do? Do you guys put on really good direct primary care conferences? And I was like, oh my God, have we failed? So just a little bit of background on the company. In my opening remarks, I think I gave some, but you know, this company's been around. We started Hint about 6 years ago. We started it to help enable the growth and success of the direct primary care movement, which we strongly believe is an innovation that if it was to get to mainstream, it would have some of the most profound impact on the healthcare cost, access, and outcome crisis that is our U.S. healthcare system. That's what motivates us every day to go to work, and we just see ourselves as facilitators and enablers of the brilliant direct primary care organizations that are brave enough to move in this direction. That's what gets us up. We discovered years ago, studying direct primary care, that as we were looking for challenges that direct primary care organizations were having, or challenges that doctors were having who wanted to get into direct primary care, challenges that direct primary care organizations that were growing and scaling were having. You know, we're looking for barriers and challenges that we could help to solve so that they could stay focused on the fundamental reason why they went into the model in the first place, which was to spend 95% of their time on patient care versus in the traditional fee-for-service world as a fraction of that, and allowed them to grow and scale very cost effectively and efficiently, maintaining the purity of the model and the focus on the patient. And what everybody kept putting our nose in was the administration of the payment model, which we kind of thought was going to be really simple. If you're not billing insurance, I mean, you know, get a credit card processing system and a spreadsheet called a day. But what we learned back then that became the insight that became the foundation of the company is that, you know, for all intents and purposes, direct primary care doctors are bringing health plans to market. They are not health insurance plans, but they come with them all the administrative complexity of offering and bringing plans. I need to enroll people. I need to manage eligibility. I need to get paid. I'm going direct to consumer. I'm going direct to employer. Now I have multiple locations and doctors and employers and consumers, and it just didn't scale. They were throwing one FTE per 600 to 700 members, one administrative FTE per 600 to 700 members to manage all that stuff. Blows up the model, doesn't scale, gets in the way of the essence of what the model is designed to do. And so it was that insight that led to the creation of Hint and the creation of a platform that continues to evolve that just makes that whole part of the model really simple. So that's what we do as a company. We also do an enormous amount of education. We also support a lot of the legislative work, both at the federal and state level, anything we can do to get involved in this movement to unblock its ability to grow and scale. We created Hint Summit, right? That's another asset that we created to bring this community together. It's part of what we do. Really, because everyone is heads down in their business. There isn't really a forum today. There's a couple of great DPC conferences, the DPC Summit, DPC Nuts and Bolts. phenomenal conferences. You should consider attending them. They're really designed, they're like one-on-one classes, or kind of like, they're the one-on-one crash course for a doctor who's thinking about DPC. And man, you rip through that weekend and you know everything you need to think about in terms of starting your practice. They're great conferences, but there isn't a forum for the more advanced, growing employer-focused direct primary care organizations. That's really what Hint Summit was designed to do. So just to get grounded on who we are and what we do when we get up in the morning. So I want to spend a little bit of time talking about the partnership that we have with Health Rosetta that's really just kind of become formalized over the last few months. Building on Sean's talk and talk about the work that we're doing to help their advisors. And Jen's on the stage because we're actually starting to expand our platform to productize a lot of the work we've been doing manually, working with advisors across the country, that we also believe is going to be exceptionally valuable and relevant to our direct primary care organizations that are growing and scaling with employers that also share similar challenges. So let's get into that a little bit. So I thought I'd start with just a map, essentially, of the direct primary care, in America today. There's a handful of directories or maps out there you guys have probably been to, like Phil Eskew's DPC Mapper, which is a great map. That represents about 65% of direct primary care locations today. So there really is no definitive source. That was the first problem we started seeing about 4 or 5 months ago. That's tracking, because obviously DPC is growing too, but a definitive consolidated source of every direct primary care location. Now again, there might be one entity with many locations on this map, but we've built a database that we're constantly evolving and tracking every direct primary care entity in the country. All the red dots in this map represent all the direct primary care locations today. The dots in blue are our direct primary care organizations on the Hint platform. So a little over 1,500 DPC locations. Hint, folks that are on the Hint platform represent about 75% of that. In addition, we're also powering 9 different direct primary care networks that are starting to evolve in the country. Some of what you saw represented today. Strata Healthcare, NextEra Healthcare, MyMD Select are examples of those 9. Believe it or not, we also have health systems that have reached out to us that are starting direct primary care initiatives. Because I think they too are trying to figure out how to get to the future. And this phenomenon is happening, and they're trying to understand, they're creating a clinic or 2 or 3 or 4, and they're starting to take that to market to understand how that might fit into their kind of portfolio in the marketplaces they're trying to serve. You heard from Ben Aiken, Dr. Ben Aiken, who started Avenue Clinic for Mission Health that was recently acquired by HCA as an example of health systems starting to get into this game too. But what's happened is that, and this was kind of by design, I think, over the years, we've always been laser focused on one entity in the healthcare community, which is direct primary care provider organizations, helping to unlock their ability to grow and scale and support them. Then you start to have maps that look like this, right? So what's happened to us over the last, I'd say 6 months to a year is, we now get 5, 6, 7 calls a month from benefit advisors we've never met before, and they'll reach out, and some are Health Rosetta benefit advisors, some might not be, but they reach out to us because they kind of have learned about us through the grapevine, and they're reaching out to us because they've been talking to their employers in the community about direct primary care, and they're trying to understand some really basic stuff about whether or not direct primary care could be a viable strategy for their employers in their market. Because there's very little resources to figure that out. It's really actually quite tough. So the classic questions, right? 5 to 6 to 7 days, or times a month when an advisor calls. Mike, are there any DPC physicians out there, like in Cincinnati, Ohio, right? Are there anyone that are kind of near my employers? Do they have any interest in actually working with me, with more sophisticated employers and kind of going down that path? Can you make some introductions to the folks you think are really good that I should talk to first? To even sales cycle stuff that they're doing, Mike, what's the best way to define direct primary care? If I'm talking to my employer, about really good primary care and I'm saying direct primary care, what is that? How is that different than other things like on-site nurse, like clinic companies that I'm familiar with, for example? Is there any data out there that kind of substantiates that what they're doing is actually moving the needle? That's going to be important in the conversations that I have. And then, so that's just basic questions about what this animal is to help arm them to have better, more informed conversations with their employers. let alone as we move down that path to actually starting to build a plan around DPC. There's actually, what would seem simple actually gets very complicated in terms of just operationalizing the business relationship, operationalizing the administrative challenges associated with trying to get something up and running. That stuff actually is kind of brand new territory too for a lot of advisors and employers in markets that are trying to work with community DPC. So, so these kinds of conversations with benefit advisors, we're also being approached by health plans, right? You guys heard from Decent yesterday. You heard from Sedera yesterday. Those are two example organizations that reached out to us with really the same kind of challenges and questions. Hey, we're very excited about the power of DPC. We want to start to build DPC-centric health insurance products for individuals, right? Which is different than a benefit advisor trying to do with a self-funded employer. Are there any docs out there? Where are they? Does anyone want to work with us? And how can we operationalize this to make it actually work for everybody? So as this map has become, continues to grow, I think that more and more people that have to purchase healthcare and trying to be more innovative with it are seeing direct primary care as an incredibly valuable new strategy and tool, and we're being pulled into that to help to start to work with those types of entities to help to solve for it. Does that make sense? Okay. So we've worked kind of loosely with the Health Rosetta, known them certainly for the last, since we started the company. In fact, I think Zach Holdsworth, our founder CEO, would certainly say that one of his, I think he discovered direct primary care reading Dave Chase articles when he was writing about direct primary care 7, 8, 9, 10 years ago almost in his Forbes column. And that Dave in those articles was a big part of the inspiration, education and inspiration for him to want to start to build a company to enable it. So we've known the Health Rosetta for a long time, but it's kind of gotten to a point now as their advisor community has grown, as their advisor community is getting smarter and more educated on direct primary care, and their advisor community wants to try to start to move that strategy forward and start to think about how to build built on DPC plans. That we need to work more closely together to help to solve for many of those issues. So, and what the Health Rosetta, and Sean alluded to this today, we didn't go into it great depth today, is that they're building technology that's going to help to democratize the ability for a benefit advisor to build and operationalize Health Rosetta-centric plans, kind of high-performance plan infrastructure. And we're going to be working with the Health Rosetta to kind of integrate our platform into that whole process to make the incorporation and integration of DPC as simple and as simple and as efficient as possible. So that at a very high level, that's the work that we're doing with the Health Rosetta, technically and operationally. And then we're also doing a lot of work with the Health Rosetta and their advisors to start to build essentially education to solve for some of those issues that I take in phone calls manually. It's about 20% of my time today. And fit 20% of my time in discussions with benefit advisors the last couple of days to help to make that information and insight more liquid as well. Okay, forward. So there's really kind of 5 ways that again, part of my goal today to the direct primary care organizations and the communities to help them understand how we're starting to help advisors, because I think it may actually create a lot of inspiration for our direct primary care clients to help us and to arm us to help those advisors in the work that they're doing as well. But kind of 5 areas that we're helping. Now, one is education, right? As I mentioned, there's just a lot of kind of 101, 200 level class education on what this direct primary care animal is and how it works, why it's different, why it's better. Number 2, this is a material issue, which is great. Now that I've got employers that may want to move forward with it, who's out there? Who wants to work with me? And today that work is done manually. I mean, I'm probably working with 5 or 6 benefit advisors right now across the country with our map and our database, and getting on the phone and calling James and Emily in Orange County saying, I've got an advisor I want to introduce you to. They're doing some really interesting work. And Clint will call me once a month and say, hey, Mike, I've got a deal. And who's the best doc in Tampa Bay, Florida? And I would call Eric Kroll, sitting in the audience, and say, you got to meet this guy, Clint. And I think you guys could do so. So all that's happening kind of manually. So we're looking to build tools to make all that process faster and easier and more efficient, both for the benefit advisor who wants to find, connect, and create a community of DPC that they want to work with in the community. But it's really the same challenges that our are direct primary care organizations that are building kind of larger affiliate networks are having and trying to scale and support and find the supply to support the employer deals that they're starting to expand with as well. That's the curation concept. Implementation, right? So once all that's agreed, how do we actually operationalize those relationships? I remember spending a lot of time with Patrick Roll and Tina Wilt, who you guys heard speak yesterday. Spent some time in Pennsylvania with them, talking with those guys and the employer on, and their TPA on, so how are we going to enroll the patients, and like how do they choose the doctors? There's not really a system for that, and how are we going to pay these folks, and how do we let them know when people come and go from the company? Even really basic kind of enrollment, eligibility management, payment, that type of infrastructure, because direct primary care doctors do not submit claims, doesn't really exist out there off the shelf. And so our technology platform is increasingly helping to solve for that. So implementation issues like that. In the direct primary care world too, we're very protective of the model, so to speak, right? There's some really important principles in direct primary care in terms of keeping the third parties out of care delivery, allowing free market, the free market to be able to really persist in DPC, which is a really important concept. Price transparency, allowing patients or employees to choose on their own, to pay on their own. So there's some really careful, kind of nuanced issues that are very, very important and valuable in the direct primary care market that when you start to work with employers have to be managed very carefully and thoughtfully so that you don't, so we're not trying to just move direct primary care practices, or they're not moving themselves down a path that could look like where they came from. So there's a lot of sensitivity and thoughtfulness that has to go into just architecting those business relationships, those contracting relationships, those pricing structures. And they differ and they range out there, but benefit advisors have to understand that, be sensitive to that, because otherwise they'll find that there's no direct primary care doctors that want to work with them, for example, or some that do, but they'll be missing the point. So how do you protect kind of this really delicate, beautiful innovation that's direct primary care in the context of moving it forward with more sophisticated employers? Administration, I think I just touched on. That's kind of the fourth area. And lastly, evaluation, right? Which is also a really interesting and kind of meaty and touchy subject. What should we measure, right? You're working with more sophisticated self-funded employers, they want to see return on investment. A lot of benefit advisors the default thinking is well, just, we have to have, the DPC docs have to be reportable, and we'll just use the same HEDIS measures that we've been using in all other plan and load them up and have these guys do that. And it's like, no, you guys don't understand, right? That's not the right direction. And the DPC doctors will tell you first, it won't be me, that's not valuable. That's not how value should be measured in this model. In fact, it's not how value should be measured in healthcare, probably, period. In terms of how primary care doctors in fee-for-service today are being asked to be measured. In fact, in direct primary care, it's our belief that an entirely new measurement system needs to be invented that properly kind of defines and measures value in very unique ways. Then you have other tactical measurement issues, well, on average, about 75% of utilization in a direct primary care clinic is not office visits. That's the magic of the model, right? You're not forcing people in office visits. That's the fee-for-service model. It's texts, it's emails, it's phone calls, it's video chats. That's 75% of utilization, right? Well, an employer, legitimately so, may ask a question like, is anybody using the direct primary care that we've partnered with and are using? And if there isn't analytics capabilities, data aggregation analytics capabilities for all that non-structured, non-coded, non-office-based utilization capture, you can't answer that question. And then it starts to get really kind of exciting and interesting because all of that kind of asynchronous and synchronous non-office-based utilization is actually, there's tremendous correlation that could start to be made in terms of how those touch points are keeping people out of, higher cost centers of care, how they're deepening their relationship, how it's driving patient satisfaction. So there's just a brand new data set that's actually now being generated in direct primary care that traditional analytics and data systems were never designed to capture and harness. That's got to be solved for as well. So these are issues that we're very sensitive to. KPI Ninja, shout out to them. They're really investing a lot of time and energy on trying to aggregate that non-office-based coded visit stuff to leverage that. They're making great strides there. So we're working very carefully with them to help to make sure that, that's going in the right direction. So that whole evaluation area can be much more DPC-centric, much more specific, but quite frankly, be measuring the things that actually drive most of the value in the plan. because the claims that are happening outside of DPC, right, that's where it becomes very easy and obvious to see where the impact's happening. But there's, I think, much more important measures within the DPC that's not being captured today that needs to be part of the model moving forward. So those are some of the issues that we're engaging and embracing there. As part of our Health Rosetta partnership, we, question number one was, well, cool, Mike, there's 1,500 locations out there. There's a bunch of DPC docs. We know that not all of those doctors necessarily want to work with more sophisticated Health Rosetta benefit advisors. I mean, there's a segmentation in direct primary care today. And there are plenty of phenomenal direct primary care doctors that just want to take care of 200, 300, 400, 500 patients, people in their community, consumers, call it a day, right? There's others that want to be less than that, just have a good, solid, lifestyle business. Never want to add a partner. The concept of working with employers sounds complicated and, they don't need it. That's great. Beautiful. There's just different objectives of different direct primary care organizations out there that need to be understood, because benefit advisors need to be working with those organizations that actually want to partner with advisors to do the kind of work that we've been talking about for the last day and a half. So one of the things we launched about a month and a half ago was an initiative that, we just started this initiative, but basically asking every direct primary care organization in the country to opt in if they are, at the very least, ready, hopefully willing, and then maybe evolving to able to want to go down the path to do some really, really fabulous, sophisticated work with Health Rosetta benefit advisors to maximize the opportunities of the structures that they're putting in place with employers. We have about 110, I think, direct primary care organizations that so far have opted in. We've barely started this initiative, but the idea is that the Health Rosetta advisors need a directory. They need, at the very beginnings, just a list, right, of doctors across the country in their communities, because a map that has lots of dots, that's a subset of which might be interested in working with them, let alone, dots on a map help you, but, really understanding like what they're doing and how their model works and are they interested in working with you, and I need female doctors, not just male doctors, and just really basic information, right, about the docs that are out there that are interested in, or that are ready and willing and able. This is like the 101 basic information that we're in the process of assembling just to make it easier for a Health Rosetta benefit advisor to know who's out there, know that they're excited to work, to talk to and work with them and start to build those relationships. So that's one of the initiatives that we have going on. Let me pause there. Questions, comments, input? Pretty straightforward? Okay. I'm going to hand the baton to Jen, who's going to take us forward. We may or may not do this audience poll. I'll let Jen know, or Jen will tell us. But I brought Jen here because I thought it's important for us to start to share with you some technology product concepts that we're building and evolving to help to solve some of these issues, because we want to get your perspective on it.
Great. Maybe clicker. Good morning, everybody. I'm very excited to be here. And as I shared with some of you when I met you yesterday or this morning, I actually came to the HINT Summit last year as an attendee and left kind of with like DPC stars in my eyes. I was so excited and so energized about everything that I heard from this community that I decided I had to actually be part of it. So here I am, fast forward about 10 months. And I've just started a couple weeks ago, but we've started on some concepts and things about how we can take the challenges that we just had a really rich discussion on a little while ago, and how do we start making that easier. So even when I left last year, being so excited and energized, that big question of how are we going to move where we want to be? And now that we're kind of moving into even more complex worlds with employers, thinking about how we can actually start making that happen. So if you looked fast, you might have seen some of these in Zach's presentation yesterday. But how we started this, over the last few weeks for me, but over the years for many others at HINT, we've been listening and talking and trying to figure out what are the barriers that get in your way, right? So things I've heard this week from the advisors, that people are interested, but it is so much work to try to bring all the parties together and make all of this happen. Other things that I've heard from Dr. Flanagan, I hear him say the other day, when an employer calls, I don't want to say, let me check and see if I can take care of all of your employees. I want to say just yes. I've heard from some of you as independent direct primary care providers or people who want to be in direct primary care say, I want to do it, but I need to figure out how I can connect with employers. So we've been listening and trying to figure out how we can leverage the power of the platform that we have, whether things that we already have today, new things that we need to build, so that we can figure out how to start accelerating the things that you're already out there doing. So a couple concepts to show you here. So this one, what you're looking at, could be used by anybody who, this could be advisor, it could be a large provider that is actually trying to sign an employer and doesn't have enough capacity or doesn't have locations in everywhere that they need to be. So this first step, which was a big learning for me even in the last couple weeks, is it's not just about finding doctors, it's about almost qualifying a region. So based on an employer and their census and who they have in their population, is this even a good fit for my region? Are there doctors out there? Are there enough females, males, pediatricians? Do they have the kind of services that this employer wants to cover? So this starts getting in, kind of starts at a regional level and looking from that perspective. All right, and then you would kind of drill in, say you qualify the region and you say, this would really work. Then you get into actually finding and identifying the provider. So this is where, as we're building and curating this list, it's great if we just have the list, but it's much better if we can make that list actionable. And then kind of getting, again, into operationalization. So that's a lot of the stuff that we do today. So you may not be able to see this super well. But this is where we're saying, okay, great, everybody's come to the table. We've helped accelerate that to happen. You're looking at something, if you use it today, you would recognize the patient list, but up there in the top right, a little something new. What if you were being notified that you just got 20 new enrollments through all this work? So you didn't have to go out there and do all the marketing. You weren't having to go, necessarily do all this work yourself to connect to the employers. That through all of this connection that we would facilitate, within our platform and with the Health Rosetta, that we can essentially find these enrollments for you and start taking that work away. So we know you're out there doing it, but we know that it's really hard from every single one of those perspectives. From the physician that wants to receive the patients, from the large practice that might be looking for additional affiliates, and for the advisor who's trying to bring everybody together in a region. So these are just some really early ideas, really meant to stimulate conversation and discussion to find out if these are things, would you like to be on this list if you're a provider? Would you use something like this? What else needs to be in something like this? Does it terrify you to think of enrollments just being, kind of showing up at your door, or does that excite you? So those are the kind of things that we want to hear from you. And I think we probably have a few minutes if anybody had any thoughts they wanted to share today. But we'd also really love to talk to you after today. And from whatever perspective you're coming from, whatever stage you're in, this could totally miss the mark for you. And I would love to hear that too. What are the kind of things that we can do so we can start making all of the wonderful things that you want to do easier for you to do and make it possible for you to do? Do we have a mic and come over this way?
Thanks. Hi. From an advisor perspective, how do we access this? Because step one to talk to an employer is going to be, are there any docs around? Mm-hmm. Or I don't even want to, you know what I'm saying?
Yep, so this is what the partnership between Health Rosetta and Hint coming to life might look like, right? So this would be something new, and you would actually be using it in this case. If that makes sense.
Thank you.
Any other thoughts? Can't see out there.
I know everyone's probably sick of hearing from me. One quick comment of like how painful this situation is we're working with a plan right now that wants to do DPC conceptually. And there are 800 employees, 600 are in one facility, and that are in one location. And luckily that city has pretty decent coverage. But they have 50 people in Houston, Texas, 50 people in California, 2 locations, and then the other 100 people are across 15 different states. And so from their perspective, yeah, they could start with just that local location, but then it's sort of creating a bit of a, employers are always worried about their outliers that are sitting in other places. It's like this tiered, like, oh great, everyone else gets the super awesome thing and I have this crappy old thing. And so some employers look at it and say, well, I'm either gonna do everything or I'm not doing anything at all. And so this is where this employer is, if they're saying, well, we need to solve this before we tackle primary care, because I've got, as you saw, I've got all these other things in my plan to tackle. So if I can't tackle everything, I'm not going to tackle anything. And there are 523,000 companies between 50 and 5,000 employers in the employees in the country, and that's a lot of challenge. So as David was saying, just this one basic thing gives him and other advisors the confidence to actually go in and even have these discussions, never mind get through doing them.
So I think this is very interesting. One of the things I would say as a doctor is, in days gone by, insurances would say to patients, pick your doc, and they'd pick a doc even if you didn't have the capacity to see them in a prompt manner. And so I would imagine it would be fairly simple to just notify the physician that you're working on some patients, approximately how many, because a lot of times those patients will then want to promptly come into the office. And if you suddenly get 100 patients who want same-day service, you can't always deliver on that. There's a practical, like, human bodies, time, volume kind of thing. So that would be the one feedback I would give.
So maybe not even just simple capacity, but limitations on how much capacity you might want at once. And obviously there'd be a lot of communication in here on that front, but this is the depth that we want to get to, because it's not just as simple as saying, I could take 100 lives. You might not want to take 100 lives all at once, or at least be prepared for that. Yeah, that's a great point. Thank you.
Yeah, I appreciate the focus on employers as a cohort from which to draw patients for DPC practices. Is there any organized way to reach out to independent contractors or self-employed people who are, earning but not organized, and the free people?
So we certainly think about, when we think about our clients, right, there's kind of I'll use the term, the consumer, right, or the individual, right, and then employers. And in terms of the individual, that's consumer marketing, right? We are investing more and more to kind of document best practices, let alone look for technology tools that can help to automate or help facilitate best practices in consumer direct primary care marketing. We've learned a lot about consumer marketing and direct primary care over the last 4 or 5 years, but generally speaking, it still requires quite a bit of education, right? I mean, direct primary care is a physician-driven movement in this country today. It is physicians that are leaving a very broken system. The consumer in America is not pounding the table going, where's my DPC, right? But there is best practices there that can be formalized that we're working with clients on. That's kind of an internal issue that we have to help with the consumer. The other aspect of individuals is that we're intrigued with is, what organizations like Sedera or Decent, I think those are 2 beginning organizations, right, who are bringing, DPC-centric complete healthcare solutions, and those organizations out there doing marketing, right, to attract people to their solutions that serves to help drive individual growth in your practice as well. And I think that those types of entities we're intrigued with because they're more leveraged plays. I mean, trying to market one-to-one to patients. I'm looking at Jason Larson at Assurance Health right now, who you guys heard talk to. I mean, he's probably one of the more sophisticated, and you should speak to him, more sophisticated DPC consumer marketers in the country, I would say today. It's hard, it's still hard. But best practice is important there. But as other entities, whether it's an employer, but let's leave them out for a second, but like what Decent and Sedera are doing, and I think we're just going to see more and more of that, of people wanting to build, much more innovative, right, much more cost-effective total healthcare solutions, I'd refer to it, instead of like an insurance plan, because it could take lots of different forms, that want to grow, right, but that you're embedded in. So I think that those areas and those kind of partnerships that we're developing, I think, have a lot of potential to drive a lot more individuals to you, to learn about you. At the same time, let's just get better as an industry, teaching consumers what DPC is so that that sales cycle is slower and people get it and appreciate it better. All right. And one back here too, yeah. Yeah.
Can you hear me? Okay. We are a Hint user, and I can tell you we love this change. We manage our physician capacity with Hint, so that really isn't a problem for us. But the other element of it is that we have a process in place so that we onboard new members, and we do it very quickly, so no matter the number, we can take care of it. So just positive feedback. We love it.
Cool, awesome. I think, Mary?
Well, John answered.
It's not live.
Okay, John answered one of my questions about capacity. The other question about this fabulous facilitating, the match map, is the disparity in how fees have been set and how the proposals go in front of the employers. Just for giggles, I spend a lot of time going through all the speakers' websites before I came to this meeting, and I was surprised at the diversity, both from an employer standpoint and consumer standpoint, of how things are being bucketed, charged, what's included, what's not included. And I would imagine from an advisor's standpoint, bringing some level setting to that would be ideal.
I think that is a fundamental issue that needs to be addressed and will be evolved, meaning that, for all intents and purposes, these are dangerous concepts, right? But if an employer wants to work with a bunch of community DPC, right, they need to understand what that portfolio of DPC doctors are doing. How do you deal with pricing, right? Decent's actually doing some very interesting stuff as a side note where they absolutely want to maintain the ability for the direct primary care doctors that are working with them to have the pricing that they want. And we're actually helping to build tech that automates all that for them. I think other advisors might be, that may have more interest in trying to work with the direct primary care doctors in the community to normalize the pricing, to make it easier from an administrative standpoint and a cost standpoint. That raises issues in terms of kind of the free market principles around DPC, which quite frankly we think are very important too, to help make sure that the patient and/or consumer is invested in what they're buying, right? There's a real relationship there. So those are big time issues. I think as we evolve, we just need to tread carefully and learn and try to figure out how to manage for those. But those are, when it comes to implementation, those are the first 2 or 3 issues you run into right away. How's the economic arrangements going to work? How is pricing going to work? We work with advisors and say, can we just have these folks kind of normalize their service offering, right? There's big pros and cons to that. So it's a great question, Mary. These are issues that we need to embrace as we evolve and go in this direction. Any other questions? Good, excellent. So we are moving towards the finish line of the Hint Summit marathons, which they are. Here's what we thought we'd do next. We're going to start to move into getting towards wrap up. But we want to take a few minutes and hear from you guys. So this is what we love to do. For the next 10 minutes, okay? Amongst the groups that are close to you, take 5-7 minutes, okay? And discuss and write down answers to the following 3 basic questions. Number 1, what were your most important takeaways from Hint Summit 2019? Right? What's the most important takeaways? Number 2, what's the one thing you're going to do differently when you go back to work on Monday? Okay. And number 3 is, lastly, what is the most important thing you think that Hint and/or the Health Rosetta can do to help you succeed? So what I want to do is here, let's take 10 minutes, stand, grab some water, but have discussion around that. Capture answers on that as a group, more or less. And then we'll reconvene in about 7 or 8 minutes, and then we'd love to hear from you guys what the readout is on those questions. As we move into this portion, guys, into our kind of breakout work sessions, I'm going to sign off with all the folks that are currently live and watching on the live stream out there. I think we have a little over 230 organizations that are currently watching, which is a huge bump from last year. We had about 136 organizations that were watching, so we love to see attention and attendance and interest in this topic growing. So signing off for folks that are on the live stream, and I think we have our homework for the next 7 minutes. Thanks, everyone.